Jerry, that's fantastic. Thank you. So I'm speaking to you today from Mauritius, but really Leeds is my spiritual home in ophthalmology and a place I sorely miss, especially with everything that's going on and not being able to fly back there as I am normally accustomed to. And I see from the list of attendees that there are a very special hi to Fiona and to Sid as well, who was with us in Leeds until not very long ago. So I'm going to really sort of try and build on what Jerry has put forward very nicely so far in regards 27 gauge vitrectomy and technology. I've been using 27 gauge for about 3 years now, and I've had the benefit of using 27 gauge on 2 different platforms. So I'd like to put to you essentially the case that 27 gauge is really retina gauge. It's what the eye has been waiting for. It's what us vitreoretinal surgeons have to use, should want to use. And I put forward this slide here first, which is a very brief history of cutters, but I should really add this is a brief history of cutters in my hands, because those of you who are purists will know that before 23 gauge cutters came out, actually we went from 20 gauge to 25 gauge, and then we realized that 25 gauge cutters were too dramatic a transition. So then the 23 gauge cutters came along. So I've, like Jerry, had the chance I started my training with 20 gauge cutters, and I fully sort of endorsed the fact that 20 gauge vitrectomy was quite a brutal act. And I too remember taking as long, constructing a sclerostomy under the watchful eye of Fiona Bishop, who's here today. And now, clearly things have evolved very dramatically. So we have the great benefit of, and have had for some time, of being able to do essentially what we call sutureless vitrectomy with trocars, etc. And now we're sort of at the level of being able to deploy these 27 gauge rather marvelous instruments into the eye. So why such a fuss about 27 gauge? I think really as ophthalmologists who sort of spend our time looking at the eye, a very fine structure, treating it, we use technology that allows us to do some really remarkable things. It makes perfect sense that we should all be transitioning towards smaller instruments, because smaller instruments mean better wound healing, better management of planes, better cosmetic results for patients, greater room for maneuver within the eye. But this is the slide that I put up here to try and impress you all and give you the impression that I have great mastery of Newtonian physics and mechanics, but really that's not true. But it boils down to the fact that as we are using smaller instruments, we're dealing with fluid, and things slow down quite dramatically as you get smaller, and that's what Poiseuille's law tells us. So as the tube gets smaller, the radius gets smaller, things slow down quite sort of dramatically. And that's the challenge. So people would complain about, as we've transitioned from 20 to 23, from 23 to 25, and now from 25 to 27, it's the same sort of talk of, it's quite slow, it's much slower. And I'd like to put to you the argument that really, when we are working inside the eye, apart from the pressures of actually getting through lists in a timely manner and dealing with more patients more efficiently, time really should stop when you're sort of when you're working inside somebody's eye. And it's the outcome that really matters. You want to be offering your patients the best possible outcomes. We are constantly pushing the frontiers of what vitreoretinal surgery can achieve. And that's why there's so much of interest in better instruments. And so although smaller does mean slower in some ways, and we also have the issue of instrument rigidity, we are clearly sort of, using these instruments and making good progress with them. I'd like to show you a little bit about, the things that I've sort of learned myself over time. So I did my first 27 gauge vitrectomy in November 2017. And I wanted it to be 2017 because we had sort of, I had spoken to a few colleagues around and said, 2017 will be the year of 27 gauge in Mauritius. So we worked very hard to get that going. And as Jerry sort of, correctly put forward, I chose an appropriate case. Had a team around me from, at that time, I was working on the Constellation, and I chose a patient who was going to have a redo, a vitreous washout. And I thought it was going to be easy peasy, walk in the park type surgery. And I was very frustrated. It was a general anesthetic case. I had already done a complex DLAM on the patient. And I found myself struggling with the instruments. My light pipe was totally bent. And I was very embarrassed because the last time I remembered being in a situation like that was probably as a registrar doing sort of, a vitrectomy. And even then at that time, the instrument would have been perhaps, stiffer, and I managed to bend it. So it was very embarrassing, and I didn't enjoy the surgery at all. And I was very much at the end of it sort of thinking, is it really worth it? Is it worth the fuss? 27 gauge? But the very next day, I had a patient who was absolutely delighted and had a sort of eye that looked impressively untouched. And I think at that point in time, I felt to myself, there was clearly room to reconsider or to actually give 27 gauge its fair chance. I've since, it took me some time to actually do more cases with 27 gauge. It was available to me, and I gradually sort of, took on simpler cases, sometimes difficult cases. It's always a bit of a judgment call about what you're expecting. Clearly, if you are sure that you're going to use silicone oil, or if time is very much of the essence, then you might not want to sort of, take on a 27 gauge case. But now, as of, to the end of 2020, I've used 27 gauge on the Constellation, on Alcon, and I've recently transitioned to 27 gauge on the Elite over here in Mauritius, but had the privilege of that in Leeds as well for well over a year now. And I have no problem at all with 27 gauge. I think it would be my go-to. I tend to still rely on 25 gauge for things like drop nuclear fragments, very much because in one's mind, it's a question of speed and not being stuck with that fragment of nucleus that could have been removed, readily with a 25G cutter, but with which you might be struggling for some time with a 27 gauge. Or even, having a blocked sort of, cutter, as has happened to me in the past. So I don't think really that there is anything that you cannot do with the 27 gauge. I think it's very much about whether you are prepared to take on the challenge of being there for a little bit longer and perhaps, psychologically sort of contending with the possibility of a blocked instrument. But you should be able to do pretty much, everything with 27 gauge. And I'm sure that this is something that, many of you will perhaps disagree with or have an alternative opinion about. But here we go. This is what I want to say to you. We may be at the early stages of 27 gauge being the favored approach to vitreoretinal surgery, but it is almost, I think, our responsibility to take on the challenge of embracing 27 gauge in order to push the boundaries, because it is through usage of the technology that we will be able to identify essentially the weaknesses and the shortcomings and feedback and allow further progress in material engineering, in essentially slicker devices that will allow us to do things better. And I think in thinking like this, we all have to be rather convinced that smaller is definitely better for the eye. I'd like to show you a few videos of my cases over here, where really you can sort of see the versatility, or perhaps in some ways the simplicity as well, that comes with using 27 gauge technology. And I've sort of broken it down into a few simple things. So I think in the previous talk by Jerry, you saw essentially two cases, but clearly involving trocar insertion, etc. I think we all know that as soon as we went from manually constructing sclerostomies with MVR blades and dissecting sort of scleral flaps, etc., as soon as we got to the trocar, things became a lot easier and a lot faster. So 27 gauge trocar insertion as well makes it easy peasy, really simple to put in an instrument to be able to get going what is the most important, which is getting into the eye, into the back of the eye. So it's truly straightforward, one step. You don't really have to sort of tunnel it in one way and then go down. It's minimally traumatic, atraumatic sometimes. You could say transconjunctival is what it's been purported to be for some time. But here's what I'd like to propose to you as well is we talk about entry side breaks, and I've always thought about exit side breaks. We don't call them that way because we used to have cases where, let's say, for instance, with 23 gauge vitrectomies, I remember we all do a search. It's very common practice in the UK when we are trained. So we complete our surgery with a search of the peripheral retina to make sure that there are no breaks left behind. And some of these breaks, when they're called entry side breaks, the mechanism is that when you first put in your trocar, your instrument, you drag the vitreous, and you drag the vitreous such that there is a tear produced. But what about when you withdraw your trocar at the end of surgery, when you withdraw your last instrument, that little bit of vitreous that you leave behind, that you haven't sort of shaved off, that gets dragged into your instrument as you pull out and gives you the break that will then lead to that retinal detachment that you wonder about afterwards. So clearly, smaller instruments, less by way of traction, less mass of vitreous means potentially fewer retinal detachments that arise from exit side breaks or conventionally entry side breaks. Hypotony. When was the last time that, if you are a small gauge retinal surgeon, when was the last time that you actually had to deal with hypotony, after vitreoretinal surgery? And even I had this tendency to continue to fill the eye with a little bit of air just to, more or less treat my own anxiety about hypotony. But I have given up on that a long time ago. So for routine cases, there's no question of having to put air in. And equally, you get the satisfaction of a patient who, like for a cataract operation, wakes up afterwards or, comes out of the theater and says, "Woo, I can see." And that is phenomenal. I mean, it's a great thing to be able to offer that sort of an outcome to patients. Endophthalmitis, you could argue that in a very general way, as you make things smaller, neater, you're reducing the risk of infection postoperatively. And I haven't sutured a single 27 gauge vitrectomy. In Leeds, I held the sort of a record for suturing the first 25 gauge port. I think that's what my scrub nurses said to me. But 27 gauge, I've never sutured, never had to suture. And clearly, there's the issue of faster recovery from surgery. So the next slide is really the videos to tell you about how. I hope that the video will come along. Video clip. So I should click on that to push it to you. Yeah, there we go. Let's push it to audience. So the next videos that you're going to see, and I hope I can see them as well, are just what I put together to show you how neat essentially surgery is at the end when you're doing 27 gauge. You remove the trocars effortlessly, and the eye looks very much untouched. And I do peribulbar blocks, OGA. So the nice thing about them is that you realize the subtenon block makes the eye look a little bit ugly sometimes, whereas a peribulbar is a bit neater. And clearly, when you're doing a GA, the eye really looks like it's not been operated on at all. And I can tell you certainly in a place where before I came, the standard was 20 gauge, vitreoretinal surgery with oil inside every eye. This makes a phenomenal difference to the reputation of retinal surgery in this part of the world. the other thing as well is I don't know, like perhaps some of my sort of surgeons of my kind of generation in some ways, when we started with valve trocars, it was always said that, look, put in an instrument so that when you're withdrawing it, there's no traction from the vitreous. But you'll see in one of the videos here, as I'm completing, I chose this video because it's the one where I realized, why am I doing that? Because there'll be minimal traction. You can literally, and I saw Jerry do that as well in his video, you can just pull the trocar out and the wound seals. So you're pretty safe, I suppose, with respect to the conventional risks or the risks that were previously associated with larger gauge surgeries. The other point I'd like to make to you as well is that essentially, we relied on quite a few different instruments depending on sort of the types of surgeries that we did, and 27 gauge instruments offer you a fair amount of flexibility as well. So, you can do some things with them that you would have previously required other instruments for, or that you would have considered to be, I thought would be impossible. So, for instance, the 27 gauge cutter vitrector, I use the one currently, the Bi-Blade, is fantastic at 7,500 cuts a minute. Traction is actually minimal, and you can work very, very close to the retina, and I'd like to show you that in the next video, which is a video of a tractional retinal detachment that I was where I had to do sort of segmentation and delamination. I hope the video is coming through to you. Darren, I'm not sure, is the video okay? I think we skipped the video there by mistake.
Yes.
I'm sorry about this. I think it's video 2 that I wanted to show. Yeah, there we go. I hope you can all see this video, but I've used triamcinolone to actually stain the vitreous, and I'm working really, really close to the retina. I'm doing something that would have been considered to be a sin in days gone by. You'd never take a 23 gauge cutter or a 20 gauge cutter with the opening oriented towards the retina and your foot down on the pedal. Whereas I am doing that here. I am controlling my vacuum, of course, but you can see there's absolutely no movement of the retina. And if your screen is big enough, you see that I'm quite effectively, shaving the vitreous that's on the surface. Clearly, in this case, I'm trying to create as much laxity within the retina as possible in order to reattach it subsequently. But it feels very, very safe. It's very, very controlled. And it's certainly even better than what you could do with 27 gauge instrumentation. This is the kind of thing where if you had a case like this before, you'd be perhaps thinking of a bimanual approach. You'd be worried about creating iatrogenic breaks. You might leave some vitreous or more vitreous behind than you would actually sort of be able to remove. It does make an enormous difference. And this also illustrates the point about, the argument about time. When we talk about time, we talk about the time to remove the vitreous. And I'm going to show you this in another video. But a lot of the complex work that we do, perhaps even not to use the word complex, a lot of the work we do is actually, past removing the vitreous. It's where you want to add safety to the work we are doing. And really, you can spend a lot of time, managing the complications that arise from the work that you've done inside the eye. So if you create iatrogenic breaks, you then have to treat them. You have to consider laser, cryotherapy. If you actually avoided breaks altogether, you've made your life a lot easier. So the next video that I want to show you is essentially where it's about. Really, I've speeded up the actual video, but this is about the cutter and just It's an eye which has a bog standard vitreous hemorrhage, diabetic, one of many that I get over here, and it's the 27 gauge cutter bi-blade. This is a video that lasts just under a minute, and you can actually see, and I've speeded up by 8 times, so it's 8 minutes to actually remove all the vitreous, or nearly all of it. And it actually does feel very, very efficient. It could be 8 minutes with the 27 gauge. It might have been 5 with the 25 gauge bi-blade. But we're really not talking about a lot of time, and certainly a few extra minutes invested into the procedure for a lot of return in terms of a better outcome, a happier patient, and so on. So I think all of that makes it well worth it. I've also talked to you about the versatility of the instruments, and I haven't. These are things that you figure out as you're going along. So I've put together these 2 videos as well to show you how, for instance, you can, instead of using a conventional back flush device, you can actually use the cutter very, very safely and as a back flush. And I can't see the video coming up. I hope it will. Probably takes a little bit of time. There we go. Active aspiration. I hope it comes up. Yeah, there we go. So this is a retinal detachment repair in a patient with Ehlers-Danlos syndrome, and you see me refilling the eye with a little bit of water because I actually used the back flush first to drain, and the back flush drainage 27 gauge was a bit slower, so the actual break closed, and there was still a fair amount of subretinal fluid. So I filled the eye up again, more or less, the break reopened as more fluid got in, and then I used the cutter to actively aspirate very close to the break, and you can see. I don't know, on your screens, you can see the waves of fluid coming in towards the cutter port, and I'm doing a simultaneous air fluid exchange, and it works beautifully. And so you realize that you need fewer instruments, and your instruments you're more efficient. So perhaps what you spend by way of time with your vitrectomy is gained with your instrumentation. I realize that I'm sort of perhaps going over time a little bit. The other video that I wanted to show you very quickly, and I apologize for taking time, is of the cutter being also very versatile. This is a hot DLAM, so somebody who with an only eye who came along with active proliferative disease. We gave some ranibizumab before, and then 3 days later was operating. And you can see very well here, so that there's this dense fibrovascular membrane and tractional detachment. And what I've done here is I've done a cutter delamination, pretty much, use the cutter as instead of a scissor. And it works very, very beautifully. So, there is an economy of movement, there is an economy of instruments. You get to know your instruments better, their limitations better, and of course, you use them more efficiently as well. I've told you all the great things about 27 gauge instrumentation and surgery, and hopefully I would have convinced you, if you were a little bit hesitant about going down this route, that you should certainly try it. It's very true that 27 gauge is not at its best just yet. It's work in progress, but it's not a problem, because we have, if you've done 25 gauge, 23 gauge, you can always go back to those instruments as you require them. I've mentioned here things like if you're inserting silicone oil, you might want to change a trocar, heavy liquid, as Jerry said as well, drop nuclei. But I think, clearly these are just boundaries that are waiting to be pushed. And of course, the instruments are constantly getting better. Smaller is better for the eye. That's the message I want you to take. We should all transition to 27 gauge instrumentation, and we should look forward to 29 gauge instrumentation. I have a bit of a bet with one of my colleagues about who will be the first to try 29G, and I think if we all use 27 gauge, we will be driving innovation and making things a lot easier for everyone. My final sort of slide is to say to you, 27 gauge is retina gauge. Look at these screws here. If you want to do the job with the right instruments, you'll get a better result. Thank you very much.
Thanks, Sia.
I'm sorry for having taken so long, by the way. I apologize.
No, not at all. Just a comment. I think with 20 to 25, 3 to 25, 27, you know, we train fellows in Glasgow, and there's a couple of guys who use scissors, and there's a couple of guys, 2 or 3 of us, who use the cutter for pretty much everything. And sometimes the fellow looks at you when you're using your cutter for delamination, and they look at you and they think you just got lucky there, you know, by trimming that membrane. And you do it again, and you can feel them lucky again. And by the end of it, you say, "Is this?" As the cutter is getting smaller, you know, from 23 to 25 to 27, we're not getting luckier. The technology is getting better, and delamination is becoming easier. You know, if you're opening up to do a delam open up a 19 gauge port to put a 20 gauge pair of scissors in, the amount of traction you're creating with those scissors and entry site breaks and vitreous incarceration, when you can open a 25, 27 gauge cutter and use it like a pair of scissors, and the luck is becoming, you know, if you watch that video you showed of the delam there, you know exactly what you're doing there. It's not luck, but to an outside looking in, it looks like you're getting lucky. But you're getting lucky again and again and again, and it's not luck, it's technology advancing.
I agree.
So we're going to move on. Any questions? Any more questions here? Not too many questions here, guys. Obviously all very self-explanatory, but any questions, just hit it up in the Q&A box and we will respond to them. So we're going to move on to Kurt's talk here.